Okay, let's just see if people are making their way in. It's always nice at this point saying making their way into the room, the virtual room, of course. I don't know how long I can rely upon saying the virtual room because I'm sure in a few years we'll be used to Zoom calls and online rooms, indeed. Okay, we see people coming through, which is great. So, yeah, hello, everybody, and welcome to today's webinar in association with the DigiFit MSK project and the European Pain Federation, EFIC. We're here to discuss patient-centered communication in MSK pain and how we can make every word count, as you can tell in the title. As always, we have the absolute privilege of being joined by some world-leading experts in this space, and I'll be very happy to give the floor or even the screen to them very shortly. It's fair to say that we have some very influential people in the field of MSK pain management with us, and I'm really looking forward to the discussions today. So first of all, of course, thank you all for joining us. And I'd like to very quickly take this opportunity to explain a little bit about the webinar, how it's going to go, and how you can make the most of today's session. So this is a live webinar, of course. Therefore, we encourage you to engage with our wonderful panelists here today. It's not often that we have a chance to have such fruitful discussions. So I encourage you to use the live Q&A function at the bottom of your screen. You might be familiar with Zoom now. You can submit questions here or thoughts that you might have. You can also do this anonymously if you wish to do so, and we will get through as many as possible throughout today's session. Unfortunately, due to the numbers, we aren't able to have people ask over the microphone. So please get your questions written down as soon as possible. We're expecting quite a few, so get them in as soon as, and we'll be answering those after the presentations. There's also a chat function. You can use this for general comments. It doesn't have to be a question. It can just be a point that you want to raise. And with this in mind, the chat function, we'd love to hear from you right now. So please let us know. Pop into the chat where you're joining us from, and perhaps even a little indication to your background. Maybe you're a medical professional, maybe you're a researcher, a clinician, a student, whatever it might be. Let us know in the chat right now. We'll come back to those in a moment. A reminder that this is also a recorded webinar, so you can access these discussions at a later time if you wish to do so via the online resources for DigiFit MSK, and we're going to let you know exactly what that is very, very soon. And of course, the EFIC Academy website and YouTube channel. So we can see many people coming through, which is great. 10 physios from Denmark, all surrounded by one computer. Brilliant. That's great stuff, technology this day. Miriam from New York University, people from Basel, Belgium, Denmark clinicians. Great to see you all. US-based PT, an osteopath from Rome, Sue, Oscar, Kirsten, Francesco from Italy. Great to see you all. Thank you so much for being here. And of course, lots of ways to engage in today's session. So, okay, that's enough from me. That's enough of my talk. I'm Nathan, your host today. But I'd like to hand over to our first panelist, Dr. Victor Domenech, who is going to give us an insight into the DigiFit MSK project, which sits at the center of patient-centered communication in MSK pain management. Victor, thank you so much for joining us. If you'd like to go ahead and give us an introduction to yourself and, of course, the DigiFit MSK project.
Thank you very much, Nate. I'm going to just use a couple of minutes to introduce the project, the E4MSK project. I would like to say also thank you for Peter to accept being on this webinar. This is an honor for us. And we are also very honored for having so many participants in this webinar. I'm going now to share my screen. Well, the intention of introducing the project is that we hope that we are going to let you know different outputs that we are going to have over the following months that hopefully will be valuable for clinicians, lecturers, and academics. Well, this is the Digi4MSK project. It is an Erasmus Plus project from the called Innovation Alliance for Musculoskeletal Health Literacy in the Digital Era. As Nathan has said, I'm the coordinator with my colleague Pablo Bellosta. We both coordinate the project which started in October 2023. It is a consortium of several partners from different countries, from Spain, Ireland, Italy, Austria, Denmark, and the EFIC located in Belgium. When we developed the idea for this project or the proposal, we thought about, of course, the problem of musculoskeletal disorders affecting a significant part of the population, and how we could help the healthcare system to better tackle this problem of musculoskeletal pain, and to help reduce the different problems related with it, such as the presence of low-value treatments and the pressure on the healthcare systems. Our aim was to improve the lack of fast translation of scientific knowledge regarding musculoskeletal health literacy and self-management to both healthcare professionals and also the general population. So the outputs that we are going to release or to finish with its production over the following months are intended to target these two populations. And we have adapted the content for professionals, but also in a more simple way to the general populations and the patients, of course. And we wanted to create new methods and content for education, or to educate these two groups. When we planned the production, we thought about different questions, such as we wanted to respond to these questions with scientific production, such as is self-management or self-management strategies, are they effective? What is the relevance of musculoskeletal health literacy or health literacy in the musculoskeletal field? And we also wanted to know what's the digital behavior or the relationship of both professionals and patients with the content or musculoskeletal health content on the internet, in terms of, for example, how many web online resources they seek for, how often do they do, if they are satisfied with this content, if it is helpful for them, for healthcare professionals and also patients, etc. And also, we, for example, are about to publish different questionnaires about to evaluate this digital behavior in people with musculoskeletal pain. Some of these outputs are already available for free in our webpage, so I encourage the audience and the attendants of this webinar to download these free resources. You can access through the QR code that you are seeing on the screen, and please use it, and hopefully it will be valuable for you, such as, for example, the long report that we have on digital behavior of both patients and healthcare professionals. And I'm going to be more specific about the outputs that we are producing. This is the webinar number 10, if I'm not wrong. But in the webpage, you will be able to access to the previous webinars about pain, musculoskeletal mechanisms, musculoskeletal pain mechanisms, patient communication, self-management, etc. I encourage you to access them. We are running workshops in Europe. We are about to release the book of good practice about self-management and musculoskeletal health literacy for both healthcare professionals and patients. We are also about to start with the courses pretty soon. So I encourage you to pay attention to it, because we will soon announce the release of the online free courses for professionals and also for patients with musculoskeletal pain. In September 2026, we will run a postgraduate course of 15 ECTS. And also in September, we will run our final event in the project in Zaragoza, in Spain, which is where we are located. But we will be a blended congress. You will be able to attend in person, but also online. So I've said almost everything that I wanted to say. I just let you know also that at the end of this webinar, you will have the possibility to reply to the survey, to the satisfaction survey. So we encourage you to please to fill it. It will take just a couple of minutes, and I think that Nathan will remind you later to do this survey. Thank you very much and enjoy the webinar. And thank you very much, Peter, again for accepting the invitation. And
great stuff, Victor. Thank you so much. There's really useful resources there, and I think a lot of webinars, sometimes you may struggle to find exactly what can you take today from the webinar, what can you use today in clinical practice. And I think this is a great one to show that there are resources there available for people today. So go ahead, we've popped in the chat the link to the digiformsk.eu link there that has links to all the resources that people can access that Victor spoke about there. And of course, we have a lot to come from the Digi4MSK project later this year. So keep an eye out. Hopefully it will get to you. And I'm sure that there'll be really useful resources for both clinicians and, of course, people with lived experience of pain and the general public to help manage musculoskeletal pain. Before we lose you, Victor, thank you so much for joining us. We know you're on a busy schedule today. There's a couple of questions that have come up. And of course, I encourage anybody to pop your questions in if you have any for Victor immediately. There's one there from Miriam, which says, is there a specific theme for the upcoming conference and the abstracts? And I guess, will there be an opportunity to submit some abstracts? What might the conference look like?
Yeah, the main topic, of course, will be musculoskeletal pain, but more specifically, the core topics will be self-management and health literacy in the musculoskeletal field. So anything that is related to self-management, person-centered approach, and health literacy related to musculoskeletal pain or musculoskeletal health will be very relevant topics.
Fantastic. And do we know if there's going to be an opportunity to submit abstracts yet, or is that to be decided?
We will soon release all the information regarding the Congress, and we'll circulate information, will be available on the webpage. But we will allow the presentation of short communications.
Fantastic. So we can keep an eye out for that one as well. And of course, a good example here, you can ask questions anonymously as well, is from an anonymous attendee. Is Digi4MSK using an implementation methodology to guide application strategies and standardize any further research?
No, we are having a significant scientific output, which is a way of validating our actions. But no, we are not. If that's the question about, if the question is about this, we are not teaching about how to implement investigation or research in relation to self-management. If that's the question.
And I think if there's any, I guess the question might pertain to, is there any way that what the Digi4MSK project has done, can that be replicated in any way? And I guess if people go to the website, they can find all the resources on there. And I assume they're able to reach out to you as well, Victor. They can find your contact details on the website.
Yeah, exactly. You can reach either Pablo or me or any of the other partners. But of course, in our scientific output, people will be able to see our methodology regarding our educational actions, which we have tried to done them in a scientific way. So yeah, in a way, they will be able to go through the methods and replicate how we have tried to educate both healthcare professionals and patients, and how to measure the real impact in a scientific way, etc. So yeah, this information will be available in the scientific articles.
Fantastic, great stuff. So it's all there for everybody to
see.
Sorry,
Nathan. Or even in the report on digital behavior, which is already available on the webpage. So yeah, in reality, people can definitely get inspiration for running their own research.
Yeah, fantastic. And you mentioned, of course, at the end of this webinar, we'll also share a QR code so people can give feedback. This is an iterative process. Digi4MSK are looking to try and review how education is delivered, including webinars like this. So if people can fill that in, I'll remind people towards the end as well. Once everybody's kind of, fallen asleep from the hour's webinar, I'll build everybody back up so they can fill in the survey, which we all love doing. But it is really, really helpful for the Digi4MSK group to make sure that we get it right.
Yeah, and it's very quick. So
yeah, it is very quick. Well, thank you, Victor. Thank you so much for joining us. We really appreciate that. And we will see you soon.
See you.
Great stuff. So I can see there's lots of people still in here. And of course, if you're still looking for that link to the Digi for MSK resources, if you scroll up through the chat, you'll be able to see it there. Maybe a little bit later on, we'll post it again in case it gets lost in the discussions. Brilliant. So, okay, we can now move on. Again, a huge thanks for Victor for joining us there. Just a quick reminder, you could submit your questions and comments because people do forget. But now I'd like to hand it over to Professor Peter O'Sullivan, who many of you might know is a researcher and clinician in musculoskeletal pain. And I just want to take this opportunity, just like Victor did, to thank Peter for taking time to speak to us today. We know it's the sort of the late evening and you're ready for your dinner. You've had a nice day at work, so thank you so much for joining us. But I think we can all agree that your insights into making every word count for patient-centered communication will be extremely valuable, and we really appreciate your time today. So that's enough from me. So I'm going to give you the floor to you, and I'm really looking forward to a great presentation and then, of course, a great discussion after. Thank you for joining us.
Pleasure. So nice to see all the people in the chat. And I noticed that there are people from all around the world, which is lovely. Just to be clear about who I am and my background. So I'm I'm a Kiwi by birth. Grew up in New Zealand. I came to Western Australia many years ago now. And so I'm based now in Perth, Western Australia. And before I start, I just want to acknowledge the Whadjuk people of the Noongar Nation as the traditional custodians of the land on which I am on today, and pay their respects to their elders, past, present, emerging, and acknowledge their connection to the land, waters, and culture and community. Um, uh, Longest ongoing people. So making every word count was the topic for today, and it probably should be making every word and action count. Person-centered communication and musculoskeletal pain. I'm going to focus around back pain, the leading cause of disability, but what I'm going to talk about is transferable to any musculoskeletal pain, or any clinical interaction for that matter as well. Before I start, I want to just make some acknowledgements. Research funding from funding bodies. I receive honoraria from workshops and person-centered care. And I'm a director of the Evolve Pain Care Academy, which is a non-profit social enterprise for pain education, which I'll talk a little bit about later. But before I start, just to give you a bit about my background, I'm a clinician and a researcher. I spend half my day working with people with any kind of musculoskeletal pain, predominantly long-term and disabling and distressing pain. And I spend the other part of my time researching musculoskeletal pain, management of musculoskeletal pain. A particular interest around communication and the messages that we give people through our verbal and our non-verbal cues. So to start this talk, I want to just introduce a story of a person who will give a bit about his background.
Name's Jamie Eaton, 41 years old, married with 3 boys, come back at work full time, and yeah, I've got a few hobbies, lifting weights and boxing. I got it from doing weights, so it was self-inflicted. I had a discectomy between L5 and S1. I had a nerve sleeve injection. I was a week out of having a fusion. So yeah, I was pretty bad. I went for a second opinion, went saw a physiologist, went saw a physio, 2 other physios, sorry, and they all said, look, if the neurosurgeon, if he said you need a fusion, you need a fusion. And the neurosurgeon had told me that I'll never run again and stuff like this, just stuff that I didn't want to hear. From pretty early on, I started on quite a lot of drugs. I wasn't sleeping well. Having Lyrica, Tramadol, sometimes Valium and meloxicam and anti-inflammatory. All I was doing is laying around because I didn't know what else to do. I'm dealing with 3 kids and not being able to lift up my 2-year-old and my wife, like putting her through, because I'm not moving. I'm laying on the ground. That's all I'm doing. I'm getting up for 20 minutes at the most. And, I'm just in a real bad state.
So Jamie's story, sadly, is incredibly common. Jamie, and this is throughout the world, we know this, that after a huge amount of healthcare, he was off work, he was in severe pain, he was disabled, he was distressed, he felt he'd been told he was damaged. He was become terrified of movement, any movement that hurt. He thought he was doing harm. He had lost hope for recovery, and he became quite profoundly depressed. Now, this is the story of musculoskeletal pain, where it becomes persistent and it starts impacting on people's lives. And if you look at Jamie's diagnosis, he had a number of scans where he'd been told he had a damaged back, multiple level fissures, disc degeneration, modic changes, and the L5S1. They were saying, well, that's the one will fuse. So the MRI report, he said, terrified him. Words like degeneration, disc bulges, fissures, arthropathy, arthritis, inflammation, narrowing, these words terrified him and made him think that there was no other option apart from having a fusion and living a life being limited in a way that he didn't want. So Jamie's care he described as being loaded with lots of negative messages. He'd had lots of physiotherapy, he mentioned a couple of different therapists who'd told him he had to strengthen his core and watch his posture and sit straight. This had been coupled with some other passive therapies around dry needling and hands-on exercise. He saw an exercise physiologist who gave him very similar messages around be careful with his posture, be careful when you bend, don't lift heavy loads, you can't run. His MRI scanning. So these messages are really around protect your vulnerable back, protect your damaged back. And of course, this is reinforced by the imaging, the scan that gave him really scary information that reinforced that this was a back that needed protecting and that movement that hurt should be avoided. And so he went through other interventions around various drugs, spine injections. He had a discectomy for a disc protrusion, but none of that worked. And he talked about the kinds of messages that he had been given that you need a scan to identify the cause of your pain. The disc is degenerated, it's damaged. That if it hurts, you need to rest. That you need to protect this vulnerable back. You need to sit tall and use a lumbar roll when you sit. You should avoid bending and lifting because it could further protrude your disc. You need to brace your core when you move to stabilize your spine. You should never run again. You shouldn't lift weights again, even if you have a surgery. No more manual work. And you need drugs and fusion surgery because everything else had failed. So that was the default, is you need a fusion. So if you start thinking about this, how was that for Jamie? He said that over this time, I felt unheard, invalidated, confused. No one asked me about how I was and my goals for recovery. I was just a passenger at the back of a bus being driven around a path I didn't want to go. Now, Jamie's story is sadly incredibly common, and this is a lovely qualitative synthesis that captured people's experiences of living with chronic low back pain. And this is not dissimilar to other musculoskeletal pain as well. They describe their experiences of healthcare, of being told they're damaged, of becoming distressed and disabled, of feeling stigmatized and invalidated. They describe the psychosocial impact that pain had on them, where pain became frightening, unpredictable, and threatening. There was this uncertainty for their future, a sense of loss of identity. Their attempts to cope with pain, often driven through healthcare, were around hypervigilance, overprotection, avoidance of movement, activity, work, social engagement, and then over-reliance on passive therapies and medication. And then the worst case around, being told you're damaged and you need to have your spine fused. And then these strategies to control pain involve social withdrawal from work, stopping physical activity, overprotecting movement, avoiding movement, and then this kind of juggling act where you and try to engage with some things while you avoid other things. And at the end of this journey, this kind of acceptance linked to despair. Now, many of you on this call will know that experience when you talk to patients with persistent and disabling pain. It's devastating. So what about the diagnosis of back pain? Well, we know that for a very small group, there is serious pathology, fractures, infections, malignancies. We have to identify quarter-acquainted syndrome. We have to identify those so that we can direct those people to urgent care. We know that there is another small group who may have nerve root compression, like with stenosis or with a disc protrusion, that is linked to specific pathology. But we know that the majority of people with back pain might have stuff on a scan like Jamie, but these findings do not accurately predict their pain experience or their disability or their future trajectory. And unfortunately, we give these people labels based on the radiology that is not accurate and that can be harmful. And so the question is, how do we communicate back pain to people where there is no clear pathology? Because this creates a huge challenge for us as healthcare practitioners. And then we have to ask, what is it about Jamie's experience? Why is it he didn't get better? Why is it he hurt his back and it didn't recover? It became persistent and disabling. Well, there's a lot of research now that has looked at the things that predict someone developing chronic and persistent back pain. Some of these are contextual, around contextual stress, or pain, or trauma. It could be poorer general and mental health. And so those contextual factors can then set you up for a pain event. Now, what we know around your experience of pain is that your experience of pain is influenced by lots of factors: your social environment, your family history, other friends of yours who might have had back pain, but it's very influenced by the people you see and seek care from. And so what Jamie described is this process of being told that he was damaged, of believing it was caused by an injury, that the consequences, disability, his failed treatment meant that his likelihood of getting better was reducing. There was nothing he could do to control it. Now, when you start having that mindset, that becomes distressing. And that's where you start seeing people becoming frightened and distressed and highly anxious, and they start losing stuff in life that they value, and they can become depressed. And this is often coupled with unhelpful coping responses around advice to rest, advice to protect, advice to avoid movement and activity and work, and an over-reliance on passive therapies. So this is a cocktail of basic pain beliefs and cognitions, emotions, and behavioral responses that leave people in this situation of ongoing pain and disability and sleep disturbance that sets up a vicious cycle. And it's not my job tonight to talk about all the evidence around the neurophysiological processes that can occur through the whole nervous system when these processes are in play. So the key role of the clinician is that they often perpetuate this process. And this is what our qualitative literature tells us, and certainly his story tells us. So when we see a patient come in to see us in the treatment room, what underlies the iceberg? Is that person depressed? Are they sleeping poorly? Are they have an underlying mental health problem? Is there stuff happening at home that we don't know about? Is there social isolation? Is there early life trauma? Is there pathology? We don't know unless we develop a strong therapeutic relationship. And for many patients, they don't disclose these things to us because, one, they're not given the opportunity, and two, they're not given the space, and they don't trust us with that knowledge. So communication is on a spectrum. It's on a spectrum from unhelpful to helpful. And I'm going to talk through the two spectrums today. I'm going to start with the unhelpful, and we've heard about this already in Jamie's story. So the unhelpful aspects of communication are not just what we say and do, but also how we say and do it. So what does this look like? Well, if you ask patients what they believe about back pain, they tell us a lot of stuff. This is patients who present to us as well as people in the community. There's a common belief that back pain is a serious medical condition. that it will become persistent and deteriorate. That pain is a sign that the spine is damaged, a bit like a broken machine. So if the machine's broken, you need to fix it. Now, that makes sense then that scans would be needed to diagnose the cause of your back pain. And if you're broken, it makes sense that you start avoiding movements and activities that hurt you or that threaten you. There's also a strong belief that pain is caused by poor posture and a weak core. So a natural response to this would be, I better hold my posture, I better brace myself when I move. There's a common view that pain flares are linked to tissue damage and therefore need to be responded to by rest. There's also a strong view that strong drugs are necessary when pain is severe or it persists, and when you fail treatment, that surgery is the last option and is necessary to treat the problem. Now, unfortunately, our professions have been involved in perpetuating these views. We perpetuate them through the imaging patients. We perpetuate them through telling people to protect their vulnerable back. Even in the absence of evidence to support it, we still do it. Very sadly, these beliefs are not evidence-based, and they mainly originate from healthcare practitioners. That's our job, to communicate around what the understanding of back pain. So let me give you a really clear example of this. This is a beautiful study that looked at the influence of just the reporting of an MRI scan. So 44 patients with low back pain were randomized into two groups. So they had no red flags or indication for surgery. One group was given all the factual evidence, information from the scan, a bit like Jamie. You've got disc degeneration, disc bulges, fissures, arthritis. The other group were told this is just normal incidental changes, normal age-related changes, nothing to concern you with. They then had 6 weeks of conservative treatment, and outcomes around pain self-efficacy, their functional status, and mental health status were measured across that time. Now, what you can see here is this divergence after the MRI, where the people who were given the factual information, you've got a disc degeneration, a disc bulge, their pain levels went up. Those who were told these were normal incidental findings, their pain reduced. The same was the case for their physical functioning. The people who were reassured that this was normal, their function was better. Those who were told they were damaged, their function was worse. The same thing for their pain self-efficacy, and the same for their mental health. Now, if you ever wanted to have an example of the potential negative impact on communication around an MRI report on the person's pain, their whole health, their pain, their physical function, their confidence in their body and their mental health, this should make people realize that we have to be so careful how we communicate imaging to patients. There have been other studies that have asked patients about the words that we use. Words like chronic, a couple of steps from a wheelchair. Instability, liable to pop out, not a lot you can do. Wear and tear, something's rotting away. Degeneration, an old person's spine that's degenerating. These are words that are commonplace in clinical practice that can be interpreted by the patient as something that's threatening and devastating. So Mary O'Keefe and her team have done some interesting work around diagnostic labels to ask people in the community, what would it mean to you if you were told you had a disc bulge, or you have disc degeneration of the spine, or have arthritis of the spine? The findings were that these people would say they have a greater perceived need for imaging, for surgery, for a second opinion, a greater perceived seriousness of their condition, a poorer recovery expectations, and less likely to engage in physical work and activity. This sounds exactly like what happened to Jamie. So, what is it about the communication that's unhelpful? So communication that like this can promote a negative mindset, which we know is critical for a trajectory of someone's presentation. It can create an undue focus on structure that's not evidence-based, can make people think that pain is all about their structure, It can become threatening and become worrying for them, can create anxiety and fear. It gives the perception that pain may be related to harm and damage, that pain is not maybe influenced by all the other factors that we know are important. That movement and activity that hurts should be avoided, that backs need protecting, and that we should rely on passive treatment. So these are the kinds of things that Jamie described in his journey that are so common in our communities, health communities. So what about the way we say it? Well, Rika Halapainen did some beautiful work, which was published a few years ago, asking patients who had seen a physiotherapist and other healthcare practitioners who had chronic low back pain what their experiences were like. And they described their experiences. They don't like it. They find it unhelpful when then they're not listened to or they're interrupted. When you don't validate us or consider our concerns and expectations. When you blame us for our problem, when you give us inconsistent, unclear, and scary information, when you don't involve us in our rehabilitation plan, when you don't write things down, when you're in a hurry and you rush us, when you don't follow us up, and when you overtreat us unnecessarily. And sadly, this is so common. So the people she went back to described all of these experiences around that they had around healthcare that they found incredibly unhelpful. Sadly, they're common. Ian Cow's done some beautiful work around clinician-centered communication and describing clinician-centered communication as where the focus is on the clinician's agenda, looking for clinical signs and symptoms rather than the patient's agenda, their concerns, and their emotional distress. And you can see an example. It's not just about what's said, but it's the body language. The person, the therapist is looking down, writing notes, not looking at the person and what they're saying. And the patient says, I have trouble sleeping and it's getting me down. The clinician says, and do you get any leg pain? So the patients in this situation, the patient's concerns are ignored over the clinician's agenda. And we know that this can result in the patient shutting down and not sharing information with us as well. So what are the characteristics of clinician-centered communication? Often it involves closed questions, tick boxes, not listening or responding to the patient's cues or concerns or emotions, minimizing the patient's concerns, generic reassurance. Oh, you'll be right. You'll get better. It's okay. Closing down the patients if they are distressed, feeling uncomfortable, crossing our arms, looking away. And often it's through non-verbal. Interrupting patients when they're trying to speak. The use of jargon that can alienate a patient. Non-verbal contact, non-verbal communication around lack of eye contact, closing our posture, leaning away, looking at a computer, focusing on our notes. All of these things we know can be unhelpful in the way we communicate with our patients. And this is why when we train people, we get each other to video our own consultations. And often the clinicians say how surprised they are of the way that they communicate, that they weren't aware that they did these things. So what's the impact of clinician-centered communication? Well, we know from a number of studies, I'll talk about these later, that there are poorer clinical outcomes around pain, function, quality of life. It can increase the patient's distress. There's a greater impact. It can have a greater impact on clinical outcomes than the treatment in itself. So it's so important, and sadly, communication is often not well trained to healthcare practitioners. So what about the other side? What about helpful communication? What about the things that we say and do that are helpful and how we say and do them? That is the process. So Rika's study also asked patients what they found helpful in the interactions, in the different interactions that they'd had. And they said that we like it, we find it helpful when the clinician that cares for us, takes time to listen to our worries, our concerns, and our fears. We like it when they validate us. We like it when we're reassured and our confidence is built up. We like it when we are helped to understand when our goals and life circumstances are understood. We also like it when you explain why we have pain in simple language that's not scary. We like it when you provide a plan that's flexible and adapted to our lives. We like it when you provide us with resources, when you make us aware of our body, when you put us in charge and you work as a coach, where you consider our concerns and our goals in our treatment. When you help us modify our lifestyle. So some of this is about person-centered care, the communication aspects, and others are around the content and the model of care that we provide. So what about the evidence base? So if we look at back pain, and you could say this would be the same for most musculoskeletal pain, that low back pain is very rarely a serious medical condition. Only about 1% of people. That most episodes of low back pain get better with no treatment at all. That low back pain is very rarely means that the spine is damaged. And this comes as such a surprise for patients. That scans are not needed in the majority of people with back pain. It doesn't tell you the cause of the pain. It shouldn't change the pain, the information or the way that you're treated. That avoidance and overprotecting the back actually delays your recovery. That movement and activity actually promotes your recovery. That guarding your back and holding your posture, embracing your core, and overprotecting your body may actually reinforce this belief that I need to overprotect my body. That pain flares are usually linked to stress, inactivity, poor sleep, not tissue damage. That caring for your whole health is important. Re-engaging in physical activity, managing a healthy diet, managing your sleep. And there's growing evidence for the role of whole person health around managing pain well. And that strong drugs actually are not very effective. And we know from the Opal trial that the use of opioids was actually worse than the use of a placebo drug for people with acute back pain out to 12 months. That surgery is usually not needed in the absence of serious pathology. And in fact, the outcomes from surgical interventions for persistent back pain are no different than conservative treatments, but come with significant risk and cost. So this is not the message that patients normally get. Certainly in my part of the world and in the parts of the world that I go to visit, we're stuck in this old mindset around pain equals damage. We need to protect the back. We need to scan the back, and we need to tell people to, like Jamie, to rely on passive therapies in an attempt to fix it. So sadly, this evidence-based message is often very rare and can come as a surprise, both to healthcare practitioners as well as to patients. So what about the diagnostic labels? What might be helpful? And again, Mary and her colleagues explored this. So asking people in the community, so if you were told you've got a back sprain, or you've got non-specific pain or pain that emerges without clear pathology, or you have an episode of back pain, how would that feel for you? The response was there was less perceived need for spinal imaging or surgery or a second opinion. There was less perceived sense of its seriousness. There was a greater perception of recovery, more likely to engage in physical activity and work. And so this idea of the labels that we give people or the explanations that we give people can have a profound impact on the trajectory of that, or the choices that they make, or the behavioral responses that they engage with. So what does helpful communication look like? It has a biopsychosocial focus because that's where the evidence is. It should always be non-threatening, even in the presence of pathology. It will promote a positive mindset. It will promote active self-management to put the patient back in the driver's seat of their care. It will promote a focus on whole health, not just about the spine as a structure, but the whole health of the person, their physical, their mental health, their lifestyles. It is collaborative. It's an engagement where the clinician and the patient have a conversation together and they work on a plan that's adapted to the patient's life. So this might involve messages that includes your back's really strong. It's actually pretty hard to damage in the absence of, or even in the presence of some kind of traumatic injury. We need to scan for things like fractures, but the back is really strong. That pain is often not an accurate measure of tissue damage in the absence of trauma. That disc degeneration, disc bulges are really normal as we age. That at the age of 40, about 80% of people have a disc degeneration, 60% have disc bulges, 30% have protrusions, and people without pain. That we know from longitudinal studies that these findings do not predict present or future back pain and disability. So we don't wear out as we get older, and that is the cause of pain. Engaging with painful, feared, and avoided movements and activities is safe and actually builds confidence as long as you work with a trusted partner to take that journey. And that care for your whole health, your physical health, your work health, your sleep, your diet, your mental health, and your social health are all critical for your recovery. So what about the way we communicate this? And we know there's a lot of backfire that we hear about when we start telling people, there's no pathology going on in your back, and the patient might say, oh, you're telling me it's in my head. Of course, that's not what we say. But how can we carefully and sensitively communicate with our patients? And again, I come back to some of Ian Cow's beautiful work that looks at the essence of person-centered communication, both from a verbal and non-verbal perspective. Where he explores the collaboration between the clinician and the patient, where the focus is on the patient's needs, their preferences, their values, and their agenda. And so an example of this is I have trouble sleeping and it gets me a bit low, and the clinician responds, that sounds really tough. Can you tell me more about that? So in the clinician focused example, the clinician ignored the concerns of the patients to focus on their own agenda. In this example, the clinician adheres and identifies and validates and sensitively explores the patient's concerns. So what are the key components of person-centered communication? It involves active and deep listening. It involves explicit signs of empathy, of care and kindness, both in the verbal and non-verbal sense. It involves validating the patient and their experience. It involves responding to their cues and their concerns and their emotions. It involves checking in with them that you've got the story right, summarizing micro summaries and then a summary at the end to say, let me just repeat what I've heard. Tell me if I've got this clear. So checking in with the patient. It involves reinforcing positive health behaviors. I hear you trying really hard. That's fantastic. It avoids confrontation and arguments. It involves exploring the patient's goals, their values, their expectations. It involves cognitive reassurance, not generic reassurance. It involves saying to someone like Jamie, look, I'm hearing you're really concerned about that scan. Let me examine you and come back to discussing that with you. It involves shared decision making. It involves exploring the goals of the patient. Jamie had never been asked, what are your goals? His goals were to get back to work. His goals were to get back to exercise because it was so important for his mental health. His goals were to get back to boxing and to weightlifting again because that's how he felt happy. To get back to lifting his kids, to caring for his family, to participating and socializing again. They were his goals. No one had explored those goals with him. So what do the non-verbal cues look like? Eye contact, mirroring, When the person shows concern, mirror that concern. Engaging facial expressions, body postures, that we're sitting relaxed and comfortable and open, that we're engaged, we're not standing over the person, that we're partnering with them. We can use touch and demonstration. So it's much more than just the talk. And the evidence would say that the non-verbal cues are probably way more important than the verbal cues in the way we communicate. Therapeutic touch can be empowering and validating and reassuring and empathetic. And then writing this stuff down. Very often, patients are sent home with a handout that is not person-centered, with no explanation as to what is going on, just a bunch of exercises. We're actually writing down, this is what I'm understanding from your story today is going on for you. Does this make sense? Let's film the things you're going to do and I'll talk you through it and map a plan linked to your goals. They're the non-verbals and the verbals and the non-verbals. So it builds what does the non-verbal communication do? It builds a relationship. It increases disclosure of emotional information. It signals to the patient. It provides these non-verbal cues, these to unspoken concerns and emotions. It reinforces or contradicts verbal comments. So we can powerfully communicate in this non-verbal way. So why is person-centered communication so important? Well, it's got huge benefits. It reduces the patient's level of pain, distress, and anxiety. It builds trust and alliance and collaboration. The person's more likely to come back and re-engage. It's more likely to engage with the plan that you've worked together. It facilitates conversation and disclosure. And it protects us from, as clinicians, from being litigated against. Patients don't sue clinicians they like, who care for them, even if you hurt them. And it protects us against burnout. So communication goes well beyond the interview. It's integral for the way when we examine the person, the messaging and the things that we do. It's critical in the management planning and the treatments that we deliver. Both the verbal and the non-verbal, the content and the manner in which we go about communicating is key. Now, the fact is patients like it and they want it. And clinicians who are trained in it really like it because it builds a sense of engagement and joy in the work that they do. I often say to people, you will always remember a story, but you never remember a checklist. So there are a couple of studies I want to share with you. This was a recent study that was just published in PTJ, which I came across. I thought was really lovely. It involved the capturing of 31 clinical interactions over 6 weeks of people with chronic musculoskeletal pain. The audio tapes were explored for empathetic or non-empathetic responses. So the empathetic response was defined as the clinician recognized, validated, and explored the emotions raised by the patient or not. So the audio tapes were rated for either high or low empathetic responses based on the audio. So let me give you an example of this. The pain's really getting me down, says the patient. The clinician responds, that sounds really tough for you. So that's an empathetic response. A non-empathetic response is, it's really getting me down, says the patient. And the clinician says, do you get any night pain? So in this situation, the clinician has not responded empathetically to the patient's concerns. So what's really interesting in this, and it's a small data set, but what's really interesting in this work is this is the pain intensity scores over 6 weeks. And what you see here across 4 time points, that the people who experience low empathy in the red, their pain scores weren't that reduced. The blue shows the empathetic responses where you see a much greater reduction in pain over that period of time. So the authors concluded that the more frequent empathetic communication was associated with lower patient-reported pain intensity and pain interference. So again, a lovely example of the way in which we communicate with a person can reduce their pain and their distress, and are probably more likely to engage in the things that you explore with the patient, or the treatment that you give them. This was another study, a much larger study, that was published in JAMA Open a couple of years ago. And again, it's an interesting study because this captured a really large group of people with chronic low back pain, about 6,000 clinical encounters over 24 months. And the thing that's interesting in this study is that patients were given a self-reported questionnaire. And this questionnaire asked the patient what they thought about the clinical encounter, and they had to rate it off about 10 questions. And the ratings were either from a low empathy or a high empathy score. So this is things around: were you listened to? Did you feel validated? Did the person consider your concerns and your emotions and partner with you? And did they set a plan that was aligned to your goals? So really around patient-centered care and communication. And what this study found is that in the people who had the empathetic communication, demonstrated across 24 months, or this is the 12-month, it was across 24 months, but this is the 12-month data in the figures. Reduced anxiety, reduced depression, reduced fatigue, less sleep disturbance, less pain interference. And they concluded that the high physician empathy was associated with better outcomes for everything that they measured over 12 months. The physician empathy was associated with more favorable outcomes. So an empathetic clinician was associated with more favorable outcomes than the non-pharmacological treatments, than opioid therapy, and then lumbar spine therapy in itself. So this is demonstrating that if we provide empathy, we turbocharge the care that we can give people. So it enhances our treatments, or it hinders our treatments if we don't do it. So what do we know about communication? Well, we know that some people are naturally really good communicators, and some people find it a bit harder. We know that what we think we do is often not what we do, and there have been some really interesting studies that have actually asked clinicians to rate their communication, and then they asked the patients to rate it, and there is a discordance between what the clinician thought was a great communication and lots of empathy, and what the clinician said, the patient said, actually it wasn't. There's also interesting studies looking at what we think we do and what we do. And this is why we think around training, we need to dive deep around training communication skills like we do technical skills. And for this, it requires knowledge. It requires skill acquisition. It requires mentoring. It requires practice. It requires feedback, and it requires repetition. And this is what we've been involved in the work that we've been doing. And I want to talk a little bit about CFT as a model of care. Now, it's not the only model of care. It's just the model of care that we've been involved in that makes sense for us as clinicians and seems to work to be well accepted by patients. And we'll talk a bit about the evidence for it. Now, CFT is very interested in the training of clinicians to not just what we do and say, but how we do and say it. So there's a very strong focus around person-centered care, but also around guideline-based care, about the things that we do. This is around person-centered care that is individualized to the person's contributing factors and to their goals. And I'll talk you through these three key pillars: the making sense, the exposure with control, which is really just building confidence back in the body to re-engage in value activities, and then lifestyle change. So during a person-centered interview and examination, so someone like Jamie might present, and we would use an Orebro screening tool. with him to say, right, let's screen you and look at what's going on. Now, Jamie had really high scores. He had high scores on pain and disability. He thought he wasn't going to get better. He wasn't sleeping. He wasn't working. He thought he wasn't going to get back to work. He was distressed. He was depressed. So he ticked every box. So that screening tool then allowed the clinician to explore these things through his story. So the first question might be asked, can you share your story with me, Jamie? And of course, the patients are like, whoa, where do I start? Where did Jamie start? He started from the position of, I used to be this fit, healthy, strong guy. I was strong at work. I loved playing with my kids. I was the fit, strong guy, and I needed that for my mental health. And it's all gone. And now I'm in a terrible situation. I've got a damaged back and I've been told I need surgery. I don't know what to do. So that open question opened the door to his concerns, his values, his emotions, his sense of loss, his goals of where he would like to go, but is also his sense of despair. So within that process, we explore the patient's beliefs, their emotions, patterns of avoidance, protection, perceptions around their body, the messages they've been given, their goals, expectations, their lifestyle, their social situation. And then during the examination, we explore the things that they tell us that they're frightened of, the things that they avoid, the things that are the barriers for them re-engaging in valued activities like work and engaging in activity or picking up the kids or lifting weights. And so for Jamie, bending and twisting was terrifying for him and he thought it was going to damage him. And so through that graded exposure process where we sensitively explore the patient's beliefs and emotions, get them to dismantle those protective behaviors, we explore their ability to re-engage in a non-protective way with the things that frighten them and that they avoid. And on the basis of that, we go through a clinical reasoning process where we start exploring what are the key factors in Jamie's presentation. Well, from lifestyle factors, he's avoiding physical activity. He's not sleeping. He's Googling late at night. He's avoiding movement and activity. He's socially isolated from his friends. He's not working. He has these beliefs that have been given to him by the healthcare practitioners. He's pain vigilant. He's lost his confidence. He's frightened and distressed and anxious and depressed. He's highly sensitized around his spinal structures to palpation and to movement. Sure, he has degenerative changes, but so do lots of people without back pain, like Jamie. And his whole health is run down. Now, the irony is, if you go through this clinical reasoning process, the very label he's been given is the very thing that's not important in his presentation. All these other factors have not been explored in his story or addressed in his care. And so that reasoning process then allows you to start formulate a treatment that's aligned to his goals. So his goals were to make sense of what was going on, to develop pain control and to get his life back, to get back to work, to get back to the gym, to lift his kids, to get back socializing. So the making sense part is taking his story and helping him understand how his thoughts and emotions and behaviors are potent drivers of pain and disability and sensitization for him. The exposure part builds his confidence and demonstrates to him that non-protective movement and re-engaging in avoided movements and activities actually reduces his pain and builds his confidence and takes him on a journey to get back to the things in life that he values. And the importance of sleep and relaxation and healthy diet and cutting alcohol content and getting back into physical activity are critical factors in his recovery. So this care is a model of care. It's not a cookie cutter approach. It's personalized to that individual around making sense of what's important for them and chasing their goals. Takes a bit longer than normal consultations, but it trains people to learn to be in control of their journey. It teaches them the skills to self-manage. So what does that involve for training clinicians? So in the Restore trial, which I'll talk about in a minute, we trained clinicians across 6 months. We trained their understanding and knowledge around helpful communication strategies, the verbal and the non-verbal. We trained their skills, and then we mentored them while they treated patients. And we had a competency assessment at the end before they went into the trial. So what are the competencies? We train competencies around communication, around interview and examination, around clinical reasoning, and around developing person-centered care for that patient. So what do patients think about this? Well, they said it really depends on your own willingness to learn and change. They found the learning process challenging. It's like an exposure process themselves. That's what we teach our patients. It's what we've got to do ourselves as clinicians. You've got to put yourself in a scary situation. But they found there was some pushback amongst their peers where people thought it was crazy doing this stuff. You know, you got to back to your manual therapy and your dry needling. This kind of therapy where you put patients in charge is bad for your business. And then at the end of the training, they didn't say they felt masters in it. They felt competent, but they felt like they were on a new journey for learning to do something different. So the Restore trial published in The Lancet is the largest clinical trial of CFT. This involved 500 patients with an average of pain chronicity of 4 years. They were more disabled than most people who go into physiotherapy clinical trials. We tested CFT plus biofeedback against usual care. So up to 7 sessions over 3 months and a booster session. The feedback was a movement biofeedback device. We trained 18 clinicians using that training process between Sydney and Perth. And we captured outcome measures, and I'll just present a couple of them today. The pain-related disability, pain intensity, and economic effectiveness were the primary outcome measures. So what we found is that CFT resulted in large and sustained reductions in pain-related disability and pain intensity. There were large cost savings of over 5,000 Australian dollars per person over a year. It was safe and people liked it. It had high levels of satisfaction. There was no added benefit to the sensor biofeedback. So here you see that in red down the bottom, the 2 CFT arms and the usual care arm at the top. That's for pain-related disability on the left and pain intensity on the right. We published last year the 3-year follow-up to this data that showed that basically the majority of these effects were maintained 3 years after the intervention, which is unusual in back pain trials. So the mediation analysis, which was published last year in the British Behavioural Research and Therapy Journal, demonstrated that how did this intervention work? Well, what we found is that a reduction in pain, a reduction in catastrophic thinking, so a shift in mindset, a reduction in fear, and increased pain self-efficacy explained 60% of the treatment effect for the reduction in disability at 12 months. We saw a similar thing for reduction in pain catastrophizing, reduction in fear, and pain self-efficacy was greater, explained the treatment effect for pain reduction. So the interesting thing is here is when people have less catastrophic thoughts, think more positively, have more positive mindset, are less frightened and avoidant, and have greater confidence, their pain levels reduce and their disability reduces. So what do patients think about this? What's their perspective? And this is a lovely capture of patients' experience. They say, I bring to the journey my story, hope, courage, and desire for partnership. The clinician brought kindness, empathy, listening, and partnership. My story was heard. Time and space was given to hear me. I became aware of my body, learning to relax and move without protection. I developed a new understanding of my pain, understanding how thoughts, emotions, stress, and my behaviors and body responses affected my pain. And I developed control over the pain and confidence to relax and move and get back to living and engaging in a healthy lifestyle, to get active again, to sleep more better, to socially engage. I was helped to negotiate flare-ups along the way. I got back to living and learned to manage this on my own. And that's when I could start to say goodbye to the clinician. And I also found it provided growth in other aspects of my life. So CFT has been also compared to a sham intervention, which involved detuned laser therapy and neutral conversation. So it's not just about engagement, it's about the way you engage. A recent a systematic review and network analysis compared usual care, exercise therapy and psychological interventions. And CFT was the most effective treatment for reducing pain intensity and disability compared to usual care in, I think, the 32 interventions that were assessed. So there's evidence for this.
A week out of having that fusion, I found a physio. He was the last resort. And I was hoping that he'll say, you need a fusion, because I just want it all to stop. And then when he told me that he reckons he could help me, that was pretty full on. He said, you've got this degeneration, but so is most of the population. I told him, I said, look, I'm doing everything right. I'm putting the roll behind my back when I'm driving. And he said, what for? I said, well, because everyone says to do that, And he said, throw it away, like chill out, relax, lean back, He said to me, another important thing was he got me to bend over and pick something off the ground. And I was like, oh, at least, guarding and protecting my back. And he said, you don't need a fusion. You've given yourself a fusion. So he gave us stretches to do and to ride an exercise bike as well. And I was thinking, well, I can't do that. I've been laying down all day, I can't ride a bike. You think, why is my mind working against me, But it's just how I trained it to work for that 6 months or so, I'd work myself into that and I had to get out of it. And it was stretching and, people are probably going to see this. And if I say meditation, I'll start rolling in their eyes or something. But I did meditation. I went and I saw a psychologist as well. And that all helped me as well. Don't go onto the internet and read forums, because I think that people compete on there for who's got the worst, who's been chopped the most, or who's had the worst. It's just a nightmare. I went to a doctor and she said, she saw me move and she said, that's good to see you're guarding your back. Now I know now, so you hear that and you think, okay, I should be stiffening up. And what I know now is that everything I was doing was counterproductive to my recovery, big time. If I had known not to sit up apparently correctly, just to relax, chill out, throw the towel away from behind my back that was putting me into an unnatural position, not worry about sneezing or coughing. The neurosurgeon said I would never run again. I'm doing everything. Weights, I'm back doing weights again, and I go to boxing on the weekends as well. And to think that I'd kind of driven my mind, and to hear that, it's a lot to do with your mind. I think some people aren't really open to that. They'll take offense to that and think, you think it's all in my head. Overcoming that it had a lot to do with meditation, it had a lot to do with me finding other interests, because I wasn't living. I was just existing, and badly as well. It was a real bad existence. And now I can do everything. I throw my kids around, back hanging out with friends, going to work, which going back to work was really important. That helped me heaps. Just living.
Just living. And here you see a video that Jamie sent me a couple of years later. It was a program he had developed for himself. He wasn't given this by the physiotherapist, but you look at the confidence that he has in his back. He'd been told he had this degenerate back, that he couldn't lift, he couldn't run, he couldn't box, and here he is with confidence to run and jump and bend and twist his back without pain. And so often people don't get to take the journey that Jamie had. They go down the path of getting fusions and more drugs and more avoidance and more distress. So Jamie's journey involved a whole different process of understanding the contextual stresses that were occurring for him, understanding that the spine structures are sensitive, but that doesn't mean they're damaged, that your back is strong and that movement and loading is safe and that MRI does not define you, that it is safe to lift load and to twist and to bend and to use your back even if you have degenerate discs. To build a positive mindset that pain is associated with sensitization of structures, not damage to structures. It was caused by an original sprain, but down the track, tissue healing, any strain would have healed. That you can get back to living with back pain, but it takes a journey, and that journey often requires good support from good clinicians. And that, yes, you can get your life back, and that will mean that you'll have reductions in pain and disability and a sense of re-engaging in life. But that comes with developing helpful coping strategies around building a positive mindset, learning to relax the body, getting movement back. That movement is safe, re-engaging in physical activity, sleep, social activity, work, building confidence. And as you get your life back, the mood lifts. So the consequences are life back and pain relief. So what did Jamie said? He goes, I was listened to and validated as a person. I was given confidence back in my body. I understand pain did not mean I was damaged. I understood I was not defined by my MRI. I learned from my flare-ups and got my life back. So unified communication and goals across a healthcare team. Now, there are lots of barriers and opportunities for this kind of communication or care. Some of us, amongst our traditional roles, or how we've been trained, or our own professional identity. Some of it's around developing new skills and knowledge and competencies. Some of it involves being in a healthcare environment that supports us to deliver this care. But we have a health system, a community that has really strong negative beliefs around pain, that pain means damage. We have strong expectations that we want to be fixed and want to be scanned. And of course, this is really tough. So it's a tough journey to draw people down a different path. We have time constraints in health systems and mixed messages across different care providers. And we heard that with Jamie's story as well. And when we have a media that promotes, quick fixes, I think Elon Musk put out a tweet promoting disc replacements for back pain. So what are the challenges? Well, organizations like yours are really important effort to educate both the consumers and clinicians. But we need to educate society around understanding pain differently, understanding pain from a evidence-based perspective, that self-care is the best care. That involves a partnership with the clinician, upskilling clinicians in knowledge and skills and mentoring and feedback, and then making sure our care is integrated between healthcare practitioners, that we share our messages. Consistent messages are really important, and that we provide adequate time and funding to support this care. So that's why we set up the Evolve Pain Care Academy. It's a social enterprise where it's a non-profit, so all profits are used to support the mission. We provide discounted rates for people in middle and low income countries. We provide tiered learning. We have a free course, which if you're interested in this work, have a look at. And then we have online learning and then training of skills and mentoring as well. So finally, I just want to acknowledge the many, many people who have shared my journey with me around the work that we've done in my clinical journey, collaborators at Curtin nationally and internationally who have been a huge part of this work. And most importantly, the lived experience partners, people like Jamie, who have taught us so much, who are prepared to share his story with us. Thank you.
Wait for some time for my camera to come back into the room. It seems to be relaxing a little bit too much, but thank you so much, Peter. There we are. Thank you so much for such a comprehensive presentation. Lots of detail there, and we can see lots of questions coming in. Thank you so much. You can take a break, have a drink, because I know that's a lot of information to share, but we
it's
really,
always
really
pretty weird talking to yourself in a room. I'm not quite got used to this kind of talk to yourself, pretending there's someone out there, but there we go.
Absolutely. I mean, I'm sure we were all nodding and especially reacting to some of the language that you hear patients say that have been used in their pain management journey, and some of them we're just, we kind of look at it now and think it's just shocking, really, to hear these types of language being used in certain situations. Okay, let's move to a couple of the questions. I apologize that we might not be able to get through all of them, given the time that we have left. We might run over a couple of minutes just to make sure that we can get a couple of those questions through. So without delay, I'd like to dive into some of them. So Michelle was one of the first to put a question in. Michelle says, what are your best tips when you need to, I guess, sometimes gently disagree with medical colleagues? They find it hard to balance appearing respectful and stuff. What's your advice around that?
I go back to evidence. So I never make it personal. I think one of the most powerful messages. So I was fortunate to present to the Brit Spine conference last year, and I presented pretty much this talk actually, this is to spinal surgeons, and I was expecting backfire. But I reckon the story of Jamie was so powerful. I had people coming up going, this is what we say to patients. We tell people this. We didn't know this. How can we learn to do different? So I think, it's about how we would communicate with a patient is how we would communicate with our care providers. I don't think clinicians willingly tell people stuff that's harmful. I think we haven't educated our clinical community well to actually give them accurate and updated knowledge. And so, I talk to radiologists, they don't know that their reports hurt people. The surgeons, I don't think they know that they're hurting people. I think as a young physiotherapist, I trained in New Zealand. I told people not to bend because their disc was going to pop out the back. I didn't know that. I didn't know that was not helpful. I didn't, and I now look back and go, I must have frightened so many patients. So I think we have to come from a position of humility and go, look, we're all on a journey, right? And share information, share a journal and discuss it with them. We publish in all the medical journals. I mean, we publish this trial in the Lancet. We publish other work in medical journals. A lot of great work out there. It's just not shifting practice. So that's how I would approach that.
And I think this is a lot of story, and it's almost preaching to the choir. People who recognize this and are, have some humility about how they communicate in clinical practice. There are a couple of questions about is the problem also potentially systemic? These conversations, you did mention that sometimes they take a bit more effort to have and obviously require a bit more time to have those conversations. Whereas we know that in some systems, there's not much time. It's difficult.
Yeah, it's a massive issue. Look, I think, and I know we've got a number of different, I can only speak from my perspective, right? In Australia, a general practitioner has 10 minutes. Like, that is such a tough job. Basically, they've got a screen for red flags, and that we know that time pressure means it's so easy to just write a script for a medication or for a scan because it gets the patient out the door. And the patient comes in with that expectation. So to sit down and have that discussion is really tough. Physiotherapists in our country have an easier job, but not that easy, because a lot of the health funds or the funding is for consultation, not for time. And so that tends to drive short consultations. Now, we would say you don't see a psychologist for a mental health problem in 20 minutes. Doesn't happen. So they set up a model of care. Psychologists set up a model of care that fits the clientele they see. What's happened, I think, around MSK is we've come from a narrow biomechanical kind of structural paradigm, and now we realize that we have to be working within a biopsychosocial paradigm, and our treatment models don't fit anymore. And so, I personally changed my practice back in 1996. I realized I was either going to get out of the profession or I was going to change. So I spent an hour with every new patient and a half an hour with the follow-ups. Now, that's a luxury, and often, sadly, it's not funded. So one of the things that we would encourage people to do, if you have a complex case, make sure you use screening tools like the OraPro. If you see you've got, or a StartBack, if you've got a complex case, Ask the patient if it's okay with them. If it's not acute, if it's a persistent problem, if it's okay to break the consultation across 2 sessions. And that time it sets an agenda. I don't think any patient's going to go, no, I don't want you to spend time to listen to my story. Because you can start the conversation with, it looks like you've got a tough problem here. And the beginning of, like, set the agenda straight up. So I've got half an hour, I've got 20 minutes. I really want to hear about your story. But this looks like this is a significant problem for you, and it's distressing. Are you okay if we take a couple of sessions over this to deeply explore what's happening, examine you, and set you up with a plan? That's how I would address this from a time perspective.
Always such an issue. I'm just going to very, very quickly go ahead because I'm aware that some people might be leaving on the dot. Please let me know if you can see this. I'm trying to share the satisfaction survey. If you are able to see this on your screen, I hope it's visible for everybody. Please scan this QR code so you can give us, as I mentioned before, and as Victor mentioned at the beginning of the session, just some feedback about today's session. I think it's been absolutely fantastic. But I guess I would say that because I'm hosting. I'm sure Peter would agree. But your feedback is very welcome. If you could spend the next couple of minutes just doing the survey, that would be absolutely brilliant. Maybe just whilst we have this on screen and people are just plodding along, providing some feedback. Peter, maybe just the floor for the last couple of minutes. I apologize to all of our attendees who popped in questions. We weren't able to address those given the time. I apologize. But Peter, what would your kind of final points be about today?
Yeah, I just see a couple of questions that have popped up, which I'd love to just address.
Go ahead.
One of
Absolutely.
them is around, does this apply to musk pain? Well, if you look at neck pain, knee pain, we've done work in arthritis and neck pain, shoulder pain. It's the same story, where you over-reliance on imaging. Of course, you screen for serious pathology, but the majority what we see in MSK pain, be it arthritis, is whole person care. So the other comment that came up was around acute back pain. I think we have to be really careful with acute back pain that we differentiate trauma versus non-trauma. We've done studies looking at people going into emergency, and there are literally hundreds of people going into emergency with non-traumatic back pain that's emerged at a time of stress or distress or a minor event. That's not a trauma, and that's often a missed opportunity to understand the context around pain. And so we're interested in exploring the role of this approach to management of back pain, both in the acute, subacute, and most back pain is a flare-up of an underlying problem anyway. It's usually not a first event. So I just wanted to clarify that thinking there. But of course, if it's a traumatic back pain, you'd manage it like you would any other traumatic injury, like an ankle sprain. You make sure it's not fractured, and that's the key. But kind of as an overview from tonight, I'm so grateful for the journey that I've taken in my career, both clinical and research. And I'm in a place now where I have a huge joy in the work that I do, where I manage a whole range of people with back pain. Now, that's not to say that clinicians don't need to work in teams with really complex cases. We need to work in teams where we work with the GP and with social work, it may be, and psychology to wrap care around a person who's really struggling. So it's not a one size fits all. It's around identifying the factors, but developing skills in communication is the skill I wish I had been given at the beginning of my journey. It's probably something I've naturally been intrigued with, but it's been a kind of a journey of self-discovery rather than a journey that I was trained in. And that's what we're trying to do now, is to actually set people up for that journey with some scaffolding around what good communication looks like.
And I think there's lots of resources just like this webinar, of course, on the Digi4MSK website as well. Make sure you access that. We've also posted the link to the satisfaction survey in the chat. If you didn't want to scan the QR code, you can access that there as well. There's been some really nice comments, not just from the question side, but in the chat as well. I would encourage that people, we will keep an eye on these resources. So once it's on YouTube or however we host this on the platform, there will be a comment function. So feel free to add comments on that and we can have some discussion after after this live kind of format as well. But I think that's probably where we're going to have to naturally finish today. I think we could continue for quite a while talking about this, as you mentioned, Peter. So again, thank you, or a huge thank you to the panelists today, Victor and of course Peter. We really appreciate your time. Did mention previously his webinar is recorded, so please feel free to share on social media, YouTube, however it is. And I think there'll be a lot of people who were unable to make the session today who will benefit from this. So feel free to share across your networks, of course, all of you. So again, thank you to all of you for joining us today, for being so engaging as well. Lots of questions. Again, apologies. We didn't manage to answer all of them, but very, very insightful. And thank you so much for your engagement. That is, of course, all from us today. I hope you have a fantastic rest of your day and, of course, the rest of the week as well. So bye for now. Thank you again, Peter.
Pleasure. See ya. Bye, everybody.
Thank you.